A very warm welcome to this year's Bentham Association Presidential Address. I know that at this stage things are a little confusing because you've been used to having Dame Hazel Genn in the position of welcoming you, but I'm the new Dean of the Faculty, Pete Akehout, and I'm absolutely delighted to see so many alumni and friends of the faculty and faculty in the room here tonight. I'm not going to speak for very long, just to say that this is actually the 70th Bentham Presidential Address. It started in 1949, so it's a really established institution, and we're extremely delighted that my predecessor, Professor Dame Hazel Genn, is delivering this year's address. I just asked her for permission to make a joke about the title of her lecture. She didn't give me permission. I'm going to make the joke anyway. Shouldn't the title be "When on Earth Are Lawyers Good for Your Health?" ? But that's really not the way she looks at it. But I will hand over to the chairman of our Bentham Association to actually say a lot more meaningful things about Hazel, I think.
Can you hear me? It'd be a shame if you can. But the only reason I'm moving over here is so you think I'm going to say a lot of meaningful things. Because I'm not. Mr. Bentham, you mustn't forget. Alumni, lords, ladies, honoured guests. First of all, another personal apology to you, Mr. Bentham. For those of you who've been here for the last 2 years, you'll realise that Mr. Bentham and I have had a difficult relationship. He is meant to be here, because this is his association. He's not only not here, he's gone off in a bit of a huff and he's now in New York. And he may not be able to hear this, I hope you can. America gets Jeremy Bentham, we get Alexander Hamilton. And soon there will be a musical, and we will export it to America, and it will get great awards. It'll be a very big show. Sorry, that's New York, and it will be tremendous. But my job is to say a few words to welcome our speaker. The point of the few words was to introduce her in great detail and tell you about her achievements. I spoke to Hazel before I wrote anything down, and she says, don't. And she said, I want you to say what you want to say. It has to be brief, however, and it has to be massively flattering. So I worked on that, and I came up with Hazel is a star, and I'd then sit down. And I realized that that was too short to be flattering, and obviously not very funny either, so I didn't bother with that one. So I then worked on all of her achievements, and for those of you who know Hazel, and I think everybody in the room either does or ought to, and by the end of the next hour and a half you will know, her achievements are magnificent. I only need to mention one, and that is she is a leading authority on access to civil and administrative justice. So I'm not going to say anything more, otherwise it would be too long, and you just have to remember that it's very flattering, whatever I say. In fact, just on flattering, for those of you who have been here over the years, this may be the 70th occasion, but I think this is the biggest audience in numbers, not in size, because that would be too personal. And I think that itself is an endorsement of our speaker. But just another word or two on Hazel, because as you will all know, she's been our dean, she's been presenting the Bentham Association events for years and years, and she has, as you know, operated a no speeches rule after the Bentham dinner. And we've listened to the no speeches for years and years. So I thought it was time that she crossed the Rubicon and gave a proper lecture. This is a serious moment for me because I'm going to say something serious at a Bentham event. This is an excellent subject. It's also perfectly timed in that the new Secretary of State the old Secretary of State, but now the new Secretary of State for Health and Social Care, has launched a 10-year, I don't know how long he's expecting to be Secretary of State, but he's launched a 10-year analysis of the relationship between health and social care, and it seems to me that after hearing tonight's presentation, he'll extend that to include law. As you can see, we're starting off with slides and spending some time with slides, but the text of the presentation, the address, will be published in Current Legal Problems towards the end of the year. Heather, you're on. Thank you very much. Hazel. I've been calling Hazel Heather and Heather Hazel for years.
If you want to do it, that's fine.
My name's Neil.
Who's nicked my glasses? That's you. Okay. Yes, it can only go up from this point onwards. Thank you, Nigel. That was a lovely introduction. Thank you for being my warm-up act. I should start by saying, and this is true, that I was really honoured to be asked to be the president this year. I was actually slightly embarrassed about it, and we had a bit of a tussle. It's a strange feeling after 9 years as dean, but actually all the more appreciated for that. It's wonderful to see so many of our alumni here this evening. We have so many loyal supporters, and it's lovely to have you in the room. There's a lovely, warm, welcoming atmosphere, and I hope that will continue throughout the lecture. Or else. I'm just going to say one thing, that I'm in a state of anxious anticipation about the fact that we are moving back to Bentham House on Monday. I had hoped that we might have been able to have this lecture in the new Bentham House this evening. It just wasn't to be the case, because unusually the project was over budget and over time. How could that ever happen? But anyway, just to let you know, we are moving back to the new building on Monday, and get your diaries out. The formal opening will be on the 25th of June. Brenda Hale's going to open the building, so just mark that in your calendars. Everyone's invited. It's going to be a lovely day. Right, that's it. I'm now going serious. My topic for this evening. The challenge of my lecture this evening is to try and bring together the worlds of justice and health. That's not always easy, because I think it's fair to say that there's been a traditional coolness, if not suspicion, between the legal and medical professions. But I want to demonstrate, or I'm going to try and demonstrate, that there are important connections between law and health, and to explain how independently access to justice research and public health research have identified the links between law and health. I want to describe how community lawyers in the UK and internationally are developing partnerships with health services to address health-harming needs. I'm going to health-harming legal needs, and I shall refer to that quite a lot later on. I'm not here dealing with heroic areas of law that have sometimes been the subject of presidential addresses. I'm focusing on what people unattractively call poor law. I'm looking at the everyday problems that blight the lives of people and disproportionately affect low-income and vulnerable groups, making them ill or making illnesses worse. So to give you a roadmap, so if you want to know where I'm going, what I'm going to look at, first of all, is what access to justice research, the kind of research that I've done and others, what access to justice research and health research tell us about the links between health and justice, to describe a practical service response and consider its benefits and challenges. And in this regard, I'm going to talk about the UCL Faculty of Law's pioneering student legal advice clinic that is integrated into a GP practice in Newham. And finally, I'm going to think about where policy and research on health justice should be going. And I'm going to say some quite robust things about that. So to start with, let's have a statistic to put things in context. This 20% comes from a survey of 1,000 GPs that was carried out in 2015. The 20% is the proportion of consultations, GP consultations, that did not actually concern medical issues. So GPs said that about 20% of the people who come into their surgeries are not bringing issues that are principally medical. Now, if you do the maths, which I've done, there are approximately 340 million GP consultations every year. That means about 68 million of them, at a minimum, concern non-medical issues at a cost of about £400 million a year to the NHS. The top 3 non-medical issues that people take to GPs are issues to do with family and relationship breakdown and children, housing problems, unemployment and work issues, so employment-related issues. 3/4 of the GPs who were interviewed said that the proportion of non-health issues coming into surgery was actually increasing, and every doctor that I've shown that to so far says they think 20% is a significant underestimate. The other implication of this is that the weight of non-health issues that are dealt with in consultations decreases the time that doctors have for health issues. It increases job stress on doctors because they're being faced with issues that they're not equipped to deal with. And in their view, it increases the cost to practice and the NHS. So what I want to do is to look at what access to justice research tells us about the links between health and justice, bearing in mind that particular statistic. Access to justice, I probably don't need to tell all the lawyers in the room, is an issue of global concern, and increasingly in times of austerity. We pride ourselves on the fact that we have written laws that respect human rights, social justice, and the protection of the vulnerable. But for any society, the question is not what rights do you ostensibly give to your citizens, but what machinery do you provide to make effective access to those rights? What machinery do you provide to make rights effective? And these are some of the questions that I'm going to address. So what do we know about access to justice and unmet need for legal advice? The research that I've done over the years has focused on looking at the problems that ordinary citizens have, the kinds of problems that they're faced with that have a legal solution, what I've called justiciable problems, what we can call everyday legal problems. Research that I did in the late 1990s and that has been replicated all around the world tells us in all jurisdictions that it's been done in that everyday legal problems are ubiquitous. That's not going to surprise anybody. That legal problems tend to cluster so that vulnerable groups tend to have more legal problems and that they do less about them. So they are able to resolve those problems less easily than other groups. The research tells us that people need legal advice to solve their legal problems, but they can't get it, that they often take the wrong path because they don't understand what kind of solution would help them with the legal problem that they have. And that there is a vast unmet need for legal advice and advocacy. The problems that I'm talking about, remember I said I'm not really focusing on the kind of big heroic problems that get up to the Supreme Court. Everyday legal problems, the problems of the vulnerable, people without wealth or power. As I said, we pass laws to protect and promote social justice, to provide protections for the vulnerable. I'm talking about people who suffer from age, gender, race discrimination, disability discrimination, domestic abuse, elder abuse, welfare problems, eviction problems, homelessness, income maintenance, immigration, employment, children and families, the kinds of things that disproportionately affect low-income and vulnerable groups. And the point I want to make, and I will keep on making, is that we give rights to those people, we give protections, but legal assistance is critical to the solution of those problems. A research on domestic violence tells us that the only service that makes any long-term difference to domestic abuse is legal assistance. So hold that thought as well. The most recent, my research has been replicated all around the world in about 20-odd jurisdictions, or 26 large-scale surveys in a number of jurisdictions around the world. The kinds of problems that I'm talking about are global problems, they're not just local problems. But the point I want to make is that the research that's been done since I did my research in the late 1990s, the research I did in the late 1990s demonstrated that people who had legal problems that they could not solve, or the legal problems that people could not solve, had a negative effect that went beyond the legal issue. There were social, economic, and health impacts. That was identified quite early on. The research that's been done since then has increasingly focused on the health impacts of unmet legal needs. And essentially, what it's telling us is something about the wider social and health impacts of lack of access to justice. So the impact on mental and physical health is particularly distinct. Stress-related ill health is most common in cases where people have experienced domestic violence, mortgage, rent problems, family breakdown, homelessness. The social costs of unresolved problems are a financial drain on other services, so there are downstream effects of unmet legal needs. Interestingly, in 2018, the most recent and the largest piece of evidence on this was carried out by the World Justice Project. The World Justice Project tries to assess rule of law conditions around the globe. And in 2018, they decided to do a study of access to justice in different jurisdictions around the world. This was a study involving 46,000 people in 45 different countries. The results, and what they did, interestingly, was actually to replicate the approach that I use in Path to Justice, asking people about the problems that they had, legal problems that they had had, how they had tried to solve them, and what impact the legal problem had had on them. The results for the UK show that nearly 2/3 of the people surveyed had experienced legal problems in the previous 2 years. Importantly, though, 40% experienced hardship as a result of their problem, and of those, about 1/3 said that they had experienced a stress-related illness. You may remember reading about this in the newspapers when this was published, because it got quite a lot of publicity. The conclusion of the World Justice Project was that with nearly half of those surveyed reporting that their legal problem led to a stress-related illness, loss of employment, or the need to relocate, this study, this global study, reinforces the impact of justice issues on people's lives. So if we didn't know it before, we know it now. Everyday legal problems have health-harming effects. We can talk about everyday legal problems as potentially health-harming legal needs. Indeed, it may be reasonable to say that legal problems are or can be health problems. Problems like income support, needing income support, problems with housing and utilities, employment, getting the right kind of education, immigration problems, personal and family security. All of these problems for which legal remedies exist, unresolved or unaddressed, can lead to harm in health. And there are two ways, I see two distinct connections between law, access to justice, and health. So on the one hand, having a legal problem, looking at this particular cycle, can end up with harming your health and end up with a kind of cascade of crises. And in the research that I have done, I have seen cases exactly like this, where you start out with with an employment problem that doesn't get fixed, and you end up with an eviction and a family breakdown. But secondly, and the access to research that's being done now is showing, is trying to demonstrate a clear causal connection that not only do legal problems harm health, but that health problems actually lead to legal problems. So somebody who has a health problem that doesn't get sorted out, that can lead to a disruption in work, and the same cycle goes on. So I hope that I am beginning to establish that there is a clear connection between legal problems, unresolved legal problems, and health. And to repeat again that legal assistance is the single right that make the other rights and protections actually viable. And we need to remember that, because that's got a central access to justice issue. Now, prior to 2012, we couldn't meet the need for legal advice and assistance among low-income and vulnerable groups, despite the fact that we had one of the most comprehensive legal aid systems in the world. In 2012, in the wake of the austerity, in wake of the global financial crisis and austerity measures, the government passed the Legal Aid Sentencing and Punishment of Offenders Act. There was a great storm of protest about it. The important thing to know for this evening is that that act effectively removed from the scope of the legal aid system all remaining areas of civil legal aid, and those areas that disproportionately affect the most vulnerable groups. I'm talking about welfare issues, housing issues, employment issues, debt issues, education issues, private family law, non-asylum immigration. All of those areas were removed from the legal aid system. What that means is if you have a problem like that, you cannot get legal aid to get legal assistance. People think that that's a picture of Kenneth Clark waving hello. It's actually a picture of him waving goodbye to the legal aid scheme that we had in 2012. Between 2010 and 2016, the Ministry of Justice experienced a spending cut of 34%. It was actually probably the largest or second largest cut to a government budget of any government department. And I have to say, and I'm not sure if there are any people here from the MOJ this evening, is that they pretty much gave it away. It had a catastrophic effect in terms of access to justice, a massive impact on high street solicitors, but an even worse effect on not-for-profit advice agencies. We had a wonderful network in England and Wales of Citizens Advice Bureau, other kinds of specialist advice agencies. They have been devastated by the loss of illegal aid because it was legal aid that was supporting their services. We've had closures, we've had redundancies, and the most recent piece of research on this, carried out by a legal action group in 2017, estimates there has been a 50% loss in not-for-profit legal advice providers since the introduction of the LASBO. The Ministry of Justice themselves, when they introduced LASBO, estimated that the not-for-profit sector would lose about 77% of its income. And they were right. They have. And it's pushing the not-for-profit sector into decline. So if we thought we had unmet need for legal advice and assistance prior to 2012, imagine what it's like now for people who have rights, who have entitlements, who are trying to get help, trying to get free legal help to assist them to make those rights effective. So what's the effect? People have the downstream effect of unmet civil legal needs is that people have nowhere to go for help. And where do they tip up? They go to the doctor's surgery, because where else are you going to go? If you're being made ill, and actually even if you're not being made particularly ill, but you need someone to talk to about it, we know from Access to Justice research that people, when they can't get free legal advice, they will go to an extraordinary range of places to get help. They often go to a police station and to other places. But the one place we know that people regularly go, the first place that they will go to talk about a problem that's a health problem that's being affected by a legal issue is the GP's surgery. And the problem, this goes back to our 20% earlier, when they go to the GP surgery, they may well be suffering from lack of sleep. They may well have increased high blood pressure. They may well have a whole series of issues. But the question is not, do they need antidepressants or sleeping pills? That's not going to solve their problem. What they need is legal assistance to sort out the problem that underlies it. And general practice is not equipped to deal with underlying socio-legal issues. So a point that I want to make here is that law has the potential to improve health where medicine alone cannot. And that's the answer to Pete's question. We can invoke the power of the law to help individuals and families meet their basic needs. When access to benefits, entitlements, rights and protections is prescribed by law, people need legal assistance. The most vulnerable, low-income people need legal assistance. We know that health can be undermined at individual and population level when people don't receive the benefits or protections that law provides. What are we going to do about it? So that's that's what we know from Access to Justice research. This is what I've known for years of doing Access to Justice research. But now I want to move to another galaxy far, far, far away. While access to justice scholars have been beavering away on these issues, scratching their head, thinking about the impact of lack of access to justice on health and trying to kind of determine the links, in another galaxy far, far away, public health researchers and social epidemiologists have been looking closely at the determinants of health. So we have two bodies of research, two armies of researchers working separately, actually on a common problem. They're getting close, but they're not sharing their perspectives. And one of the things I'm hoping to do through this lecture and writing is to make clearer the need for public health researchers and socio-legal researchers to work more closely together on how access to justice affects health. So the developments in healthcare in the Western tradition has been based on a biomedical model of health, a focus on physical and biological aspects of diseases and conditions. As you can see, the model is you have a sick person, it says sick down there, you see the pain. They get treatment, either in hospital or some kind of clinic or from a doctor, and then they are cured. And not only they're not just cured, they're made thinner in my image. That would really be something, wouldn't it? But anyway, so health services, adopting the biomedical model, health services are geared to treating the sick and disabled. They treat disease rather than people. But it's the social context in which people live that often determines health and well-being. And this is particularly true in the developed world. So research now on determinants of health, and I have to say the exact size of the pieces of pie in the pie chart depend on which bit of research you look at, but I would say that this is generally an average. So the thinking and the research in public health and social epidemiology suggests that the determinants of health are a complex interaction between individual characteristics, lifestyle, physical, social, and economic environment. The percentage, as I said, varies depending on which pie chart you look at, but most experts agree that the broader determinants of health are more important than healthcare or indeed biology in ensuring healthy populations. So genes, biology and healthcare together only represent about 1/5 of health status. So if you want to say, you know, is a population likely to be healthy or not, what you want to be looking at is less the biology and clinical care, but more those other factors. The World Health Organization has set out what it regards as the key social determinants of health, the circumstances in which people are born, develop, live, and age. They talk about income and income distribution, early life, education, housing, food security, all of those things. Health services, you see, come right at the bottom. I stress again, this is mainly in the developed world, but this is true for most developed countries. And so, thinking about it in this context, and you go back to my original 20%, it isn't surprising then that a lot of what comes into doctors' surgeries, underlying a lot of what comes into doctors' surgeries, are social issues and legal issues rather than necessarily biological issues. So we have research on access to justice, which explains how legal problems create and exacerbate mental and physical ill health. Health research confirms that health and well-being is determined more by social and economic factors than biology or clinical care. So if we are interested in mitigating the social determinants of health, then combining legal and health services may present an answer. Law, as I said before, is a powerful tool for protecting the vulnerable. Legal services can ensure that people access the social justice protections that are provided by government. So what we may be looking at now, and what I hope we're looking at now, is an argument for changing practice in two fields: the delivery of community legal advice and health services. And I think that this lecture is actually quite timely, because in the health sector, there is a growing focus on the upstream causes of ill health. This is partly to do with an inability to deal with the demand on the health services, but also a concern in looking at what are the causes of ill health. Now, the term upstream comes from what's called a public health parable. So you have to listen to the parable now. There are three, those of you who know can check your email. There are three friends who come to a river. Beautiful scene, idyllic. They hear cries of children in need of rescue who have fallen into the water, and these children are flowing towards a waterfall. The three friends are appalled. They jump into the water. The first friend goes as fast as he can to those who are about to go over the edge of the waterfall, those that are most at risk of falling over the waterfall. He swims and swims and swims and tries to pull them out. The second friend thinks and builds a raft to make sure that fewer children end up at the waterfall's edge. And over time, the first friend and the second friend are reasonably successful, but not as much as they want to be, and more people are slipping through. Finally, they see their third friend is actually swimming away from them upstream. And they're saying, "What are you doing? Where are you going? You should be helping us." And she says, "Do you know what? I'm going to go and find out who or what is throwing those children into the water." So the first, in healthcare, the first friend, the person at the edge of the waterfall, is a trauma surgeon, ICU nurse, A&E doctor. The second friend, the person with the raft, is primary care person managing chronic conditions like diabetes and hypertension. So they're giving you a raft to sit on to get you to safety. But the upstreamists, the people who are looking upstream, are necessary to begin building fences that stop people falling into the water. They're the people who are needed to organise services that start to connect people with the resources that they need outside of the doctor's surgery or the hospital, and focus on prevention. And so, in a worldwide movement, we are beginning to see a partial solution to the issues that I've raised in relation to access to justice and to the social determinants of health, changing practice in two fields. And we are seeing the development of what are known as health justice partnerships, or in the USA known as medical legal partnerships. So these are developing in the USA, Canada, Australia, and the UK. These are integrated legal and health services for vulnerable groups. They provide access to justice and address the social determinants of health. What they do is to use the trust that people have, the trust that people place in their doctors, to connect them with the legal services that they need. They develop the ability of doctors to identify and address health-harming socio-legal problems, and also equipment, put them in a position to be able to do something about it. Identifying a health-harming socio-legal problem is no use unless you have the means to do something about it. Can I just pause for a moment? Does anybody here know who that picture is? Oh. I talked to some students recently, some postgraduate students. Not a single student in the room knew who that was. What does that tell us about our age? Thank you. It's Dr. Kildare. So these health justice partnerships deal with, so what you have are doctors identifying issues, health issues that have an underlying socio-legal need, and they have lawyers who are part of the team who can help to deal with them. So what do? They combine health and legal tools to address social problems. They train doctors to identify needs. But most importantly, the concept is of embedding legal advice into multidisciplinary teams, that you see the welfare legal advisor as an essential part of the healthcare team, not as somebody who you send someone to queue up outside a CAB that may never be open, but it's someone who's there on the premises, who's part of the team, who's working in a holistic way to improve health and well-being. And what this does, where it works, is to transform community health services. So the benefits of health justice partnerships are, first of all, that they have the capacity to solve legal problems early. So that you get, if somebody turns up at a doctor's surgery and starts talking about an issue, and the doctor can refer the person to an embedded legal advisor, you have the opportunity to help the person before a crisis has occurred, before they've lost their home, before the family has broken down, before something dreadful has occurred. So it helps you to get in early. We hope that it helps, that in the end it will improve health, and that it will relieve pressure on the health service itself and on health service providers. And as far as access to justice is concerned, this is really important, because you are delivering a service, a welfare advice service, in the places that people go, the places where people go to help. The most vulnerable people do not go and access legal advice services. They don't go and queue up outside the Citizens Advice Bureau. The most vulnerable people actually have no idea that legal advice can help them with the problem that they're experiencing. For the medics in the room, because I think there are some medics in the room, medics like theory, they like a theory of change. For the medics in the room, this diagram gives you the theory of change. How does the intervention of welfare legal advice situated in a GP practice, how does that lead to improved health and well-being? The intervention is that you provide welfare advice, you provide advice on housing, debt, benefit, etc. within the healthcare setting. The primary outcome is that you get people the benefits that you need. They have more disposable income, they can lead healthier lives, hopefully you can solve their employment issues, you can deal with housing problems, you can deal with their rights and entitlements. The secondary outcome is that you reduce stress and anxiety, that you hopefully improve people's diet, reduce smoking and drinking, you increase their independence, and you improve their ability to manage in general. The tertiary, the final outcome, is that broadly you improve mental health, physical health and well-being, and you reduce the demand for health services. That's the theory, that's the idea. There is a movement in the UK called social prescribing, where doctors in general practice have adopted the practice of referring people to services other than health services. So there is a grassroots movement towards something called social prescribing. So doctors will refer people to do art classes, to do dancing classes, to physiotherapy, to do gardening, to do a range of things that might be helpful, that might help to improve their health and well-being, other than providing them with pills. There's a lot of interest in this within the NHS. There's somebody here this evening, Bev Taylor, who's a kind of champion for social prescribing. Where's Bev? There's Bev. Within the NHS. But Bev will know, and I have said this before, that the problem with social prescribing, where it is at the moment, is that welfare law services have not been seen as an essential element in social prescribing. I think we may have somebody here from the Mayor's office who's also, hi Amanda, who's also, Mayor's office, Mayor of London is also interested in social prescribing. But interestingly, they have not seen, in the range of services that people are being referred to, they have not seen welfare legal advice as an essential part of that. Now, anyone who's ever seen Maslow's pyramid of need, hierarchy of need, will know that before you can get to those other parts, the parts of not being socially isolated and all the rest of it, you need to take care of your basic needs. I did have this pyramid at one point, but then I threw it out. Anyway, on Maslow's hierarchy of need, housing, food, income security comes before issues to do with social isolation and self-actuation. So in my view, if we're talking about social prescribing, welfare legal services need to be absolutely in there right at the very beginning. The faculty, in our own way, has been contributing to this. We set up in the Faculty of Laws in 2013 a Centre for Access to Justice, and we've been providing, our students have been providing pro bono legal advice and representation for people on a range of issues. In 2016, in partnership with a GP practice in Stratford, we set up a student supervised student health justice partnership. So situated within a GP practice in Newham, one of the most deprived areas of the UK, indeed of the whole of Europe, we have set up this integrated legal advice clinic. The idea is that the GPs refer patients to us. We are based in the building. They send the patients to us. We take on their cases. We deal with their cases. And this provides an outstanding experience for our students. It gets a strong commitment to social justice for the future, no matter what career they're going to go on to. We educate the doctors within the practice about how to identify health-harming legal needs. We educate the students about that, and also we're going to do community outreach work. On top of that, we are researching the impact of our legal advice on health and well-being. This is not an easy thing to do, I can tell you. For me, it was essential that if we were going to be running this clinic, we would want to be researching it to be able to establish whether or not, or the extent to which we were having an impact on health. The paradigm kind of case that we deal with, Alicia and her baby, a woman who takes her baby repeatedly to the GP because of breathing problems and a rash. The GP diagnoses asthma. She goes back and forth, and finally, she lives in social housing that has a lot of mold, it has rats, it has bugs. Eventually, the GP refers her to our clinic. He says, go and see these people downstairs. And we write to the local authority, we contact the local authority, we ask for an urgent review. The local authority comes and reviews the property and says that the accommodation is unsuitable and she is rehoused. She had tried to contact the local authority in person, by email, by telephone previously, but nothing could be done. But this is a classic example of how the GP, seeing that the underlying problem of the baby was the housing situation, could see that we could assist in a way that every puffer in the world was not going to help. We've seen over 200 clients since we set up. The main kinds of problems that they bring to us, you can see, are housing problems and welfare benefits. We also look at people with family issues, employment issues, and to some extent, immigration issues. Everybody who comes to the clinic is included in our research. We get their consent to be included in the research, and when they come to our clinic, before they get their advice, we administer validated health and well-being questionnaires to them. We then follow them up over 3 to 6 months and repeat the questionnaires later on to see what impact we have had on them. This improvement, this stress and anxiety, is actually not from those validated questionnaires. This is what people told us. So when you say, do you feel any less stressed than you were before? Do you feel any better? 2/3 of them said they felt better, a third said the same, and 2% said they got worse. Can't win them all. But you can see that that people's perception is that it improves their situation. We are just getting out some data from our validated health questionnaires, and the early results suggest that comparing the later questionnaires with the questionnaires that were administered before they had the legal advice, the early results show that there has been an improvement in quality of life and well-being. Now, this is only a small study, it's an initial study, but our hope is to be able to expand this over time to provide robust evidence of the extent to which providing legal advice at an early stage within a health setting can have a positive impact on health and well-being. If we can demonstrate that to the satisfaction of policymakers, we may get some movement. This quote from a GP in the practice tells you, I think it confirms everything that I've been saying about the issues that they have to deal with and the difficulties for a GP who wants to do the best that they can for their client. We see a high proportion of social problems, social element to at least 1/3 of the consultations that he deals with. He says it's a lot easier to medicalize problems than to address social determinants. We have 10 minutes often with multiple problems. It's easier to ignore a problem than to try to take it on. I've had doctors who will say, I don't ask them the question about what may be underlying this health problem because I don't have the time to deal with it, and even if I had the time to deal with it, I'm not equipped to provide an answer. The co-location element is very important. If you say to a patient, oh, I think there are some people who could help you, just get the bus or the tube or whatever and go down the street, they won't go. You get referral fatigue. If you say to them, these people are in the building, just go upstairs or go downstairs and they will see you, that makes a huge difference. We've also done a mapping study. We've commissioned to do a mapping study of health justice partnerships or some form of health justice partnership in England and Wales, and we've identified about 350 services where there is some sort of connection between welfare, legal advice services and health services. There are many different models and many different sources of funding. The most common services are provided by Citizens Advice Bureau that are somehow or other linked to healthcare settings. Macmillan Cancer Support is an extremely interesting example. Macmillan have invested £200 million in providing early advice on finance and employment to people with a cancer diagnosis in an acute hospital. Wherever somebody gets a cancer diagnosis, they are automatically referred to welfare advisors to give them advice on finances and on employment. And why do they do that? Because Macmillan know that when someone is given a cancer diagnosis, the first worry is, am I going to die? The second worry is, what will happen about work and about my finances? And so it is part of the recovery package, part of the care pathway is to give people legal advice. Why don't we do that for dementia? My plan for our clinic is that we will do that for dementia in the future. These are my empire-building plans for the future. So there are a number of partnerships around the country who deliver this sort of service. At the moment, they are uncoordinated and they are unsustainable. Some of these services used to have legal aid money. They don't have it anymore. People are stitching these services together with a mixture of money from charities, local authorities, sometimes clinical commissioning groups. But they have fragile funding. These services come and go. They tend to be set up as a matter of local initiative, no proper evaluation and no sharing of best practice. There are significant challenges in trying to develop a policy, not least the problems of mistrust and misunderstanding between medical profession and legal profession. I have to say that when we first went into the doctor's surgery, when I first went to doctor's surgery in the centre in Stratford, one of the doctors said to me, oh no, does that mean everyone's going to be suing us for negligence? So there's a real education issue about what it is that a legal advice centre in a legal advice service in a health centre would be doing. So problems of mistrust, difficult to build relationships, to build bridges between legal service providers and medical profession. Doctors work under the most tremendous time pressures. They're driven nuts by the pressures on them. It's difficult for them to have the headspace to take on board what we're offering in the way of a service and actually to refer people to us. There are also issues to do with ethics and information sharing if you want to do research, but I can tell people about that over dinner if they're interested. The other problem is that there is a training issue because recognising the need for legal assistance is not something that is intuitive to health professionals. I did previously have a picture of Groucho Marx with a stethoscope around his neck, but when I showed that to students, they didn't know who he was either. I should have tried it for this audience. You knew who Dr. Kildare was. You'd have known Richard. You'd have known Groucho Marx. So the future, moving rapidly on. I am nearly finished. Dinner awaits. It's in the interest of health and legal policy to work together to improve the health of citizens. I think it's time to rethink traditional service delivery models in both health and community legal services. I think there are some real opportunities here. I think that health justice partnerships can be seen as a gateway to prevention in terms of legal problems that cascade into other things, and also prevention in terms of health, preventing people from becoming ill through being driven crazy by a legal problem. It enables lawyers to intervene before a crisis occurs, and it equips doctors to provide a more holistic service. So what do we need? This is the difficult thing. We need sustainable sources of funding from a range of sectors: healthcare, social care, legal services, local government, charities. We need coordinated policy. There is no policy. There is a social prescribing programme. There is no policy that brings together welfare, legal services and health services. We need to focus on benefit to the citizen. We need to get out of silos and think, what can we do in the way of public services that benefits our citizens? We need to integrate legal services into health settings because it's good for access to justice and it's good for health. We need to embed legal advice in care pathways. Think of the cancer example, the Macmillan example. And we need to develop a robust evidence base because we do not, at the moment, have the evidence that would necessarily convince policymakers. We need cross-government collaboration on this. This is cross-government, cross-departmental collaboration. We actually need people to be talking to each other. I had an unbelievably depressing conversation in the Ministry of Justice when I was talking about this to somebody there, and they said, seriously, Hazel, why would we be spending legal aid money on this to save money to the health budget? Now, that was the most depressing conversation. So in my imaginary world, we have cross-departmental collaboration. This is a picture of cross-departmental collaboration. It's taking place, and this is what they can see out of the window in Whitehall. And I'm going to say it now, that actually Scotland is ahead of the game on this. They actually have government funding to support embedding, and they call it embedding legal advisors in general practice. They've got 50 general practices with embedded welfare rights advisors, and it's funded by the NHS in Scotland and health and social care partnerships. So I am ending now, I promise. What we need is collaborative policy, collaborative practice and collaborative research. We need to focus on the respective contributions of law and clinical care to health and well-being. I think that legal scholars need to appreciate that health is one of the most important things that law can influence. Empirical research on law's impact on health makes an important contribution to legal scholarship. So I think health and legal researchers need to work together in interdisciplinary teams, and I'm certainly going to be doing that within UCL, and I've reached out to some people, and I'm hoping that that will work in the future. There are also opportunities for international collaboration. The women here, apart from me, you'll notice I'm wearing the same suit, different scarf. The women here is Tessa Boyd-Kane, who's the Chief Executive of Health Justice Australia, which is a national organisation promoting health justice partnerships, and Ellen Norton, who is the Chief Executive of the National Centre for Medical Legal Partnerships in the USA. We've already made connections. There are opportunities for international collaboration in terms of policy and in terms of research, and I think there's a role for a UK national centre, possibly at UCL. I think that I'm going to leave you with some challenging questions. Does access to justice buy good or better health? And could society buy better health by paying for justice? Those are just things for you to chew over dinner. But before I end, I want to thank my fantastic team, Shiva, Sarah, Matt, Jackie Kingham, Rachel Knowles and Clara Holdstock, who actually keep this clinic up and running. Sarah and Matthew have worked on the research protocol and getting the ethics approval, which was a nightmare, I can tell you that, over dinner. Doing research on health service is terrible for social researchers. The only model that they have is for clinical trials, and social research doesn't fit well into a clinical trials template. Anyway, this is my fantastic team. Most of them are here at dinner, so do say hi to them. I also want to pay tribute to the Legal Education Foundation, Natalie Byram, Jake Lee, Matthew Smurden, who have funded the research that I've been doing at the clinic. I also want to thank the Provost and our development office who have supported our work down in East London. And I want to pay tribute to Martin Rushton Turner, who's this tiny figure sitting up there. Martin has consistently provided significant support, and actually Martin's support has made it possible to do a lot of the work that we've been doing in that Health Justice Partnership in East London. And I want to say publicly how grateful we are to you for that. And I'll be seeing you later at dinner. He knows what that means. No, I shouldn't have said that because you'll leave. I think really nothing. I have no one else to thank as far as I can remember, other to thank the faculty, because the faculty has actually supported the work that we've been doing fantastically. And if anyone has any questions, but I don't think we've got time. I think we need to go to. We won't have questions. We'll go to dinner. Thank you for listening and for being so warm. Thank you. New building. Sit down now.
First of all, thank you, Hazel.
Thank you.
Hazel, many times. I wrote some notes, because I have the slides of some of them, and I ended up by writing a note to myself and to the publishers of the current legal problems. When this comes out, can we have some of the slides in the lecture? It will make such a change to see an academic article with Groucho Marx, I hope will come back.
I'll bring him back.
Dr. Kildare, Richard Chamberlain, just to cheer us up. And the last one, the doctor and the lawyer was in. I thought that was exceptional. I'm inspired, and I think we should just thank her again. But before we do, just imagine if, Mr. Bentham, you were here and you could, you'd stand. So, everybody, thank you. Excellent.